So we were asked by the Secretary of State for Health, Jeremy Hunt, in November last year to look at really three questions. One question was, should aggregate ratings be reintroduced in health and social care to look at the quality of care given by those organisations? Secondly, if so, how best to do it? And third, which organisation ought to do it? And as a result of that, we took on the task. It took us about 12 weeks, and we had an extensive engagement exercise with a wide variety of people who gave a lot of time, and we also reviewed the literature. Well, I think the first thing we found was that everyone asked us, what's the purpose of this rating system? And we identified 5 purposes that may be useful to discuss. So the first one was, could it increase public accountability? The second was, could it increase patient choice or commissioner choice of care? Would it, by providing information, help? Third, could it up performance of providers being rated? Fourth, could it spot failure and then prevent and identify it? And fifth, therefore, by doing all of the above, could it provide public reassurance? And on those, what we found is on public accountability, there's certainly nothing like a public rating to have potency in this area, and certainly we think that it could increase public accountability and scrutiny of the quality of care. That's point one. On choice, we found that potentially a rating could be useful, although at the moment patients aren't really using such information in order to make choices, and indeed their scope for making choices in healthcare, particularly of hospitals, was actually felt to be quite low. So it could be that people aren't using information because it's not scooped together in an easily available format, or it could be that the rating per se is not that helpful. But what people told us is there isn't information for them in one place, in a trusted source, that's simple enough to use. And often people need that information when, as somebody put it, they're making a distressed purchase. They want a care home for their parents, or they're sick and they want to choose a hospital or a GP. So it could be that the information simply is scattered, it's not available, it's confusing for the public, and that's certainly the case in social care. The third issue was about improving performance of providers, and there we've had ratings before, and we know that over time, the 5 years, for example, of the annual health check, that hospital performance as measured by the rating did improve, but we don't know what happened to the bits that weren't measured by the rating, and we don't know the costs of all of that either. To the providers themselves. On social care, there's far less information because ratings were only introduced really in 1 year, so we don't have that much information, and there's a marked lack of evaluation. So the feeling on performance is possibly, but really that the role of the rating itself is not. It's not just the only thing to consider here, it's also the wider system in which the rating is embedded. What is the wider system of performance management, or for example? So on failure, the conclusions of the people that we engaged in our engagement exercise, and indeed the conclusion of Francis, is that a rating cannot spot failure. The annual health check did not spot failure in mid-staffs. However, that doesn't mean to say that the ratings in future, if they were better constructed, could have a better chance of spotting failure. But overall there, what we concluded is that the rating itself would have to dovetail very effectively with a wider system of spotting failure, which is different to the rating. And that wider system we've called, in shorthand, surveillance, which uses a lot of information from a variety of sources in order to look at worrying patterns. And then, if the rating isn't going to be misleading to the public, because failures can occur in okay, good, excellent hospitals, for example, then the rating would have to have a health warning on it to say what it can and can't do. And where there are concerns about hospitals spotted, for example, by your surveillance system, then that would have to be signalled on the rating. Otherwise, it may be falsely reassuring for the public. And finally, on the question of reassurance overall, it could provide reassurance, a rating. The fact that the public know that somebody has looked at national standards and found that a provider looks good, is okay, whatever, provided that, again, the rating is not falsely reassuring. And in some cases in health, people felt that if they have no choice of hospital, then the fact that your local hospital is ranked as weak may actually undermine confidence. So again, there are mixed effects there. So overall, we felt that the rating could be helpful in all of those purposes if it were designed better than the design that we've had in the past. And then we make some very careful conclusions that if we are going to have a rating, these are the conditions under which it might have a hope of being better than the past. And one of the chief ones there is that the rating itself should be constructed in a bottom-up way through the sector. There should be a consensus about what's our best shot at the quality of care in these providers. That best shot coming from both the public and from the sector itself, not really from a top-down defined set of standards. We felt the kind of indicators that could compile a rating would be a range of indicators. It would be a mixture of data, it would be a mixture of inspections, and on the data side we'd be looking at particularly at the three so-called DARSI domains, which is what's the patient experience, what's the safety of care looking like, and what's the effectiveness of care. And then we also thought there ought to be another domain which is on governance. Is this organisation well run? There were all sorts of discussions about whether a finance element should go into this quality rating, and we felt not, because otherwise it might then skew people's attention more towards the finance than indeed the quality, and so those were important aspects. So in our analysis, we identified the key features that we thought were highly desirable in a rating organisation, which included things like it should be independent, it should have the capacity to inspect, to analyse data, it should ideally do a lot of work in surveillance to spot failures. And putting all those things together, it all points to the Care Quality Commission having that task. We also say that the Care Quality Commission, that would be a huge challenge for it, because it would have to reorientate itself from what it does now, which is a concentration on failure and also a concentration on compliance against essential standards, towards something more stretching, looking at OK, good and excellent standards. So that's quite a stretch, and as a result we think the CQC would need the resources, it would need the political support, and it would need time to develop this kind of system appropriately, rather than the chop and change that we've had and disruption in the past.